now.
Yeah, good evening, seniors and colleagues. And we are going to have our routine monthly webinar. This time the topic is on MCL injuries, which we discussed on our WhatsApp group. So we have very good speakers with us in Dr. Unmesh, who is from Varanasi and very senior knee surgeon. And then we have Dr. Arun sir. He is from Agra, again very senior arthroscopic surgeon and does a lot of work on knee surgeries. And then we have Dr. Amit Joshi from Nepal. He is exemplary in his work around knee and shoulder, and is a lot of publications about this also. He has his own technique of MCL reconstruction. So we are going to have a general outlook, which will be presented by Dr. Unmesh, general assessment and outlook of MCL injuries, and then we will have a repair technique that Dr. Arun finds very useful to him, or maybe some variation that he does. And then Amit sir will talk about MCL reconstructions. Ashish sir, I would like you to say a few words, then we can start.
Yes, thank you, Vinay. And it's a nice presentation which we are waiting for, and hope this will benefit all of us. So I welcome again Dr. Amit, Dr. Unmesh, and Dr. Arun, along with Dr. KD. Yeah. So please go ahead with the scientific material, and let's see.
So thank you so much, sir. We don't have Sanjay sir with us because he has a casualty at his home. So he is traveling right now to Shahjahanpur, so he will not be joining us. And so we'll have KD sir, and anybody who wants to ask question can put the question on the chat box. We'll have all the presentations one after the other, and the questions will be asked at the end. So Unmesh, are you ready with your presentation? Okay, go ahead. So Unmesh will be talking about MCL injuries assessment algorithm. Okay, Unmesh, all yours.
Thank you, Ashish sir and Dr. Vinay. I would like to thank AAUP for giving me this opportunity. So, is the screen visible?
Yeah, we can see.
Okay, great. So, MCL injuries. So, the assessment algorithm which I follow. So, very common presentation in our day-to-day OPDs are these patients who come to us with a fall from a two-wheeler, fall from stairs, sprain during sports, and they come with a lot of pain and limp, and they either get an X-ray done and they would be complaining that there is some pain. And once the X-ray is done, everything looks normal. So they're very happy, the attendants are very happy that there's no fracture. And most often what happens is that just give them some analgesics and crepe and they run away. But that is where we, as arthroscopy surgeons and sports injury surgeons, need to be careful, because if we don't take care of them, that's where the things can go wrong. So they would sometimes not come at all, or sometimes again come to you 2 to 3 days later with a small bruise, a telltale sign. So these are the ones which are so very common, and they actually have the story which we need to be very careful about. So it is the commonest ligament injury. MCL comprises of 40% of all ligament injuries. The good thing about is that it has got great healing potential. So even if we don't intervene, more often than not, they just do well. But what happens is that when we miss out and the patients do not take proper rest, they sometimes do not heal so well, and they can have some lingering symptoms and pain. The other good thing is that it's an extra-articular ligament. So I think all of the scopy surgeons and those who are not even doing scopy, they should be very much aware, and they can do a good treatment for these ligaments. So conventionally, we all know that these injuries are high-velocity injuries, valgus external rotation injuries happening during soccer. But in India also, with growing advent of kabaddi, kho-kho, and all these leagues, and men and women going into these international level of professional athletics, more complex injuries with associated cruciates and other soft tissues is so very common. And once the valgus injury is coming from the outer side, what we can see here, as the intensity of the force goes up, the superficial MCL, the deep MCL, the capsule, and sometimes even the cruciates, and everything just breaks apart. That's how the more force that comes in, it all breaks down. And if you're not careful and if you don't assess them well, we can miss out on this entire plethora of soft tissue injuries. So clinical examination remains the mainstay, and it's very important that it has to be done well. And again, clinical examination can only be done once the pain is less. And both the knees need to be exposed well, looked at, and examined. And for the MCL specifically, examining both the knees at 30 degrees of flexion, giving them a valgus stress, and from both the sides of the patient. For the right knee, we need to stand on the right side of the patient, and for the left knee, we need to stand on the left side of the patient. Give the valgus stress and compare the difference. And that is where we can very well see that if there's only tenderness and there's no opening, there's a firm endpoint, it's a grade 1 injury or a sprain. A grade 2, which has got mild opening more as compared to the normal side, but has a firm endpoint, that's grade 2. And these are the two common injuries. And when there is no endpoint, again, we can subdivide, but grossly when there's no endpoint on valgus stress, that is where it's grade 3, and we really need to look into these. So simply just take these patients on the couch, and we need to stand on either side of the patient. So grade 1, extension, fine. The moment you do at a 30 degree of flexion, you will see that there is tenderness, but barely there is opening. So again, 0 degree, it's perfectly stable. 30 degree of flexion, there is just tenderness. Now, for the other knee, you need to come on the other side. And with the knee flex at 30, 35 degrees, if you're giving the valgus thrust, if it is opening like this without an endpoint, that's the grade 3. So clinically, we can easily differentiate between these three things. The important thing is that in acute traumatic situation, these tests are painful. So bracing, icing, NSAIDs, and the rest remains the mainstay. Once they are settled down, and I will discuss later, no more red flag signs, then these things can be done. So grade 3 is further subdivided into grade 1 plus, where there is a 5 mm opening, grade 2 plus, that's 5 to 10 mm, and grade 3 plus, that is more than 10 mm. So grade 1, 2, and 3, and grade 3 is further subdivided into grade 1, 2, and 3. Now, that's the AMA classification revised by Houston recently in 1996. Now, if we come back to this grade 3 picture, so what is happening here? We're giving the valgus force, there is no endpoint, and it's just opening up. So we can imagine what has happened is that with this massive injury, there's a complete tear of the superficial MCL, the deep MCL, the POL, there's a capsular tear. And if there is no endpoint and it's opening more than 10 mm or at 0 degree of extension, most likely the cruciates are also gone. So that is when these associated injuries make the situation more complex. And that's where the decision has to be taken and whether and how to go about the operative treatment. So high velocity injuries, more the force, more the impact, more the number of structures which are damaged, and we need to be more aggressive about the treatment protocol. So these are the list of the ligaments. So we can quickly just have a look. The superficial MCL has the two parts, the anterior part, the superficial MCL, and behind is the posterior oblique ligament. Below it is the deep MCL, which just goes from the femur 1 centimeter down on the tibia. I think the surgeons then following lectures will explain in detail how they reconstruct it. So again, with all these things, what next? So what next? The important thing is what we have to do. What's the algorithm? How we should look at the patient, how we must approach the patient. That is the big question. So we know grade 1, 2, 3 associated injuries, etc., but what next? So MRI. So the most important question which comes up, that should we get in when and what kind of MRI we should get, and what should the interpretation be? So usually MRIs can wait unless we have a red flag sign. So a red flag sign for getting an immediate MRI is if there's a large hemarthrosis. Usually a grade 1, grade 2 tear with of an isolated MCL will not have a hemarthrosis. So if we have a large hemarthrosis, it's an indication for getting an MRI. You have already got the X-ray, there's no fracture, so look for what's the cause of the bleed. If the knee is locked, whether it's a meniscal locking or the femur locked into the MCL or the MCL locked into the meniscus or stenotype lesion, we need to do that. Suspected multiligamentous injury, like if the knee is totally wobbly, if it is dislocated or it's hyperextending or going into valgus at 0 degree, if you're suspecting multiligamentous injury, an MRI must be done. And a high demand athlete. Again, for even these small injuries, these are high demand people. Whatever you do, they will go for their exercises the next day. So that is where an MRI must be done. So MRI is simple, grade 1, you will have small signal intensity change in T2 image. On the femoral side, grade 2, there will be a tear. Grade 3, there will be a complete tear. So it's a sprain, partial, or a complete tear. That's how we used to look at it previously. But gradually, with more and more advancement and 3D imaging and MRI is being done very early on, we are seeing and learning a lot more injuries which are coming up. So again, it's very confusing how to interpret them. So there is an MRI classification. So this was given by Hadi and Omid. So type 1 is again the grade 1 clinical injury. It's a pre-avulsion of the femoral side, just tenderness, some swelling, and they usually heal pretty well. Grade 2 are avulsion injuries from the femoral side, but again, not very much displaced, and they have these ecchymosis and soft tissue swellings. Grade 3 are mid-substance tears. Now, they have soft tissue injuries, a lot of soft tissue injuries, and at the presentation, they may have instability. If managed well, they do well, they can be conserved, but we need to follow them quickly and do all the things right, remove the hemarthrosis, brace them well. Grade 4s are the distal attachments. Now, if the distally they are detached, then there is a lot of edema around the MCL. We need to look at them. If they're high demand, we have to be more aggressive. If there's associated injury, we need to look at them immediately. And we need to look at what other things are there. And the grade 5s are the proximal sleeve detachment of MCL, capsular buttonholing of the middle femoral condyles. These are the ones which need immediate intervention. So grade 4 and 5, early intervention, grade 1 and 2, conservative, grade 3, grade 4, we can decide upon when to go. So again, so how all does this help? So, well, basically we now know the type of injury, we can have a rough idea of what has to be done, and we have to individualize for high demand at one spectrum and low, very low demand at the other spectrum, and the patients who are in the middle. So isolated MCL injuries, they do extremely well if they're just grade 1 and 2, just rest, icing, NSAIDs, bracing, and early strengthening and range of movement exercises. No cast is completely out. Now, if you're dealing with MCL injuries with clinical no firm endpoints like this, that is where we need to be careful and look into, especially if it's a tibial avulsion in a high demand person. If there's an associated meniscal injury, multiligamentous injury, plateau fractures, avulsion fractures, we need to address them early. Massive avulsions with knee subluxation. Sometimes on the X-ray, you can see that the knee is subluxed. So that's a red flag sign. Most likely it's a grade 5 injury. We need to go in early. And a stenotype lesion or an entrapment on the meniscus. Any of these entrapments or locking, these are the ones where we need to intervene early. So these are candidates for early repair. Rest all can be conserved by a very patient rehabilitation with bracing, explaining the patient, giving them proper rest, medication, and aggressive physio. And rarely, if they are symptomatic, even after adequate rehab, or they have a re-injury during the rehab program, and now the injury is more, then they are candidates for a reconstruction and not a primary repair. One more thing I would like to just look into here, we can have such injuries or even less injuries, but if the lower limbs are deformed, if there's malalignment. So again, our threshold for intervention should be low. So if there are malalignment, especially valgus malalignment, these MCLs would not heal well, especially if the valgus is more than 7 degrees or 10 degrees, patient is obese or has got a slit recurvatum, they need to be looked into more aggressively. Do an osteotomy, get it done at the same time, do a reconstruction or repair, whatever the stage is. So malalignments cannot be missed out. So even smaller injuries in malalignment has to be addressed quickly. So to conclude, clinical examination remains the mainstay of decision making. Tenderness and firm endpoints indicate grade 1 and 2 and can be managed conservatively. Grade 3 MCL injuries without deformity must be given a trial of conservative treatment. The exceptions would be open MCL injuries, complete tibial avulsions in athletes, entrapments, dislocations, subluxations, stenotype, associated cruciates, associated multiligaments, associated extensive soft tissue injuries. Large hematomas and laxity in full extension or more than 10 mm of opening indicates associated injury, require immediate imaging and necessary surgery. And reconstruction is for chronic symptomatic injuries and associated injuries which need intervention. I think the following speakers would talk about it in detail. Thank you. Thank you so much.
Thank you, Unmesh. Wonderful. I think a lot of questions would be there on your talk. So we will take up the questions at the end of all the lectures. So second is Dr. Arun sir. Arun sir, you are ready for the presentation?
Yeah.
You are okay. I can share the screen. Great.
Can you see the
Yeah,
screen?
we can see, sir.
Okay. So very good evening, dear friends, and a very nice inaugural talk has been taken by Dr. Unmesh, and in which he has cleared a lot of platform regarding how the MCL injuries to be looked into. And we all know that the treatment protocols have been changing. I have attended ESACOS 2013, and that point of time, largely the MCL, even the displaced ones, were treated conservatively, and there's a role of PRP at that point of time, which was advocated by some European surgeons. But of late, as we all know, that we have gone much more aggressive and we have lowered our threshold of repairing these MCLs earlier. The anatomy has been nicely dealt with Unmesh, and that we know that the MCL is basically divided into anterior and posterior. The anterior one is proper MCL, and the posterior one is known as posterior oblique ligament. The femoral attachment is circular, and it is about 1 centimeter anterior and distal to the adductor tubercle. And the tibial attachment is more or less about fixed. It is about 6 centimeter distal to the joint line on tibial metaphysis, and it blends very finely with the tibial periosteum. And posterior, remember, it is posterior and deep to the pes insurine tendons. The deep MCL, also known as medial capsular ligaments, it originates about a centimeter proximal and distal to the joint line, and it is divided into two parts. Superior one is meniscofemoral and inferior one is meniscotibial. And it is attached to medial meniscus by coronary ligament. And this is the secondary restraint to valgus stress. The main restraint is the superficial MCL. The posterior oblique ligament is originated from the medial femur, distal to the adductor tubercle and posterior to the superficial MCL origin, and it inserts about 12 millimeters to the posteromedial corner of tibia. And it stabilizes medial meniscus in conjunction with coronary ligaments and provides posteromedial rotary stability. And this is a fine study by Robert Laprade, which has increased the understanding of the knee anatomy, especially the posteromedial and posterolateral knee anatomy. Remember, MCL has a habit of surprising you on exposure. And at times there are many times when I have, after doing ACL reconstruction or PCL reconstruction, I have found that okay, the stability is good enough, but let us see how it is sitting on the bone, the torn ACL. I have surprised to know that if I have not operated upon that patient, probably that has led to a poorer results. So if we are not prepared with proper anatomical knowledge, the skill and importantly experience, proper instruments, different variety of implants, the knowledge of them available for reconstruction or repair, we may land up in great soup and get compromised results. The MCL repair failure is very unforgiving. Reconstruction is an option, but repair, if done properly on time given, and it gives excellent results and much better long-term stability. Augmenting a repair is always an option and should be kept in mind, especially if it's a mid-substance tear. And for augmentation, we require either a autograft or a allograft or a fiber tape. Both are good. MCL anatomy, as we have discussed, is very unique in that it is a very large and long ligament, and it changes thickness, shape, and layers at origin and mid-segment, and even at the tibial attachment side. At femoral side, it is roundish, thick like a cord. In mid portion, it is like a band. There are like two bands, superficial and deep. And distal portion again, it is like a strap. It is thicker and broader and blend with the periosteum. Remember that the medial side injuries can often be managed non-surgically, almost 90%. It is generally accepted that incomplete tears, grade 1 and 2, as Unmesh has described, and the isolated tears, even grade 3, without valgus instability, can be treated non-surgically with early functional rehabilitation. Failure of non-surgical treatment can result in debilitating persistent medial instability, secondary ACL dysfunction, weakness, and at times osteoarthritis. So, coming to the point that when to repair, we know that 90% of MCL tears can heal. Also, we know that more femoral end tears heal well conservatively as compared to mid portion and distal end tears. Proximal tears, if show complete detachment and associated with ACL and PCL tear, then probably better repaired. The mid portion tear, if complete and associated with cruciate tears, usually need to be repaired and at times require augmentation. Distal end tears have to be carefully judged on MRI. If detached and in position and isolated, then conservative is better. But if they are like a Steiner lesion, that means they have buttonholed over the Passin-Serine tendons, then there are no chances of healing and they also need to be repaired. The proper instrumentation and implants, the inventory of implants have to be available, various kinds of suture anchors, interference screws, small self-tapping cortical and ligament screws, staples, suture discs, strong sutures, number 2, number 5, suture tapes for augmentation, and all kinds of drills, staple pushers, screwdrivers, tendon strippers, knot pushers, bead pins, drill bits of sizes, and guide wires has to be there in that particular constrained time area, because the tourniquet time is a constraint when you are doing concomitant cruciate ligament reconstruction as well. So that has to be kept in mind of that particular surgeon. Coming to proximal tears, I'm not going for that conservative one, which has been taken by Unmesh. So suppose it is associated with an ACL tear and it is displaced more than a centimeter, then probably 5 mm twin loaded suture anchor is required to do the job in most of the cases. If the tissue quality is not good, then we can go for a brace. You can see here that we are tapping in a femoral attachment site, a double loaded anchor with a suture tape as well. And the MCL from the femoral side is repaired with the number 2 fiber wire. Into the femoral footprint of the anchor, and then the posterior oblique part is also taken into the account and sutured back. And then POL is attached to the proximal part of the superficial MCL as well. And remember, we have a fiber tape which is here in the femoral footprint. If the tissue quality is not good, then we can brace it from superior to inferior about 6 centimeters down on the tibial side to brace or repair. Remember, beware of the dimples which are present in the knee joints when you get a patient in the emergency. I presume most of us have seen these kind of patients in our OR or in our OPD, these kind of dimples in the knee joint. And this means usually that the MCL is invaginated in the medial side and it has totally avulsed from the femoral side. And you see in this MRI, it has gone into the joint. So This is the buttonholing of the femur. The femur is lying just underneath the skin. As soon as you open, as you clear the hematoma, you can see the medial part of the femoral condyle. The whole MCL along with the capsule has gone into the joint. You need to just deliver it and fixed accordingly with the help of double loaded suture anchor, depending on the size of the patient knee joint. Unfortunately, I'm not able to run this video of this repair, but you can understand that this is just an easy method to repair with the help of suture anchor. Coming to the mid-substance tear, which are more required with the to augment with the help of fiber tape. So this is a picture in which the MCL is torn, in which the end-to-end double breasting repair is done, and then it is bridged by fiber tape with the help as depicted in this pictorial diagram, which is bridged by an internal brace with number 2 or number 5 fiber wire in both the sides. Coming to the distal tears, displaced distal tear, which buttonhole as in this MRI over a hamstring tendon, as depicted in this pencil diagram, will not heal conservatively. And at times, if they are also not buttonholed or they are, bit from tear from just below the deep attachment and the distal part is still underneath the pars and tendons, they also do not heal properly and they will require repair. So in this video, we can see that this part of the MCL, after clearing from the sartorial fascia, you can see it is totally avulsed from the underlying bone. The hematoma and the fibrosis is cleared, and a twin loaded suture anchor is placed about 12 millimeters from the joint line in the line of MCL. The bone at times is quite hard, and then it is required to tap before hammering your anchor. And then with the help of this twin loaded suture anchor, place all 4 sutures into the deep path coming out of the superficial part of this torn part of MCL from the tibial side. This, you can see that. And then put a small 1 centimeter incision at the medial epicondyle, at the footprint of femoral MCL. Tap it and putting a double loaded swivel lock suture anchor and railroad the fiber wire over distal double loaded suture anchor. Tap it, the fiber tape brace, put a hemostat underneath the fiber tape so that it is not very tight when you are tightening it. Put a hemostat and then tighten the swivel lock. And with the remaining suture in the swivel lock on the tibial side, one can repair the distal part of the MCL just underneath the pars and tendon and can check for the stability. So it's an algorithm which one can use, that when the MCL is isolatedly torn, grade 1 and 2, conservative treatment, grade 3 with normal alignment or varus still can be treated conservatively. If there is a valgus or MCL entrapment of the distal part of the MCL or a bony avulsion, acute repair is indicated. When there is a combined MCL-ACL injury, a conservative MCL or delayed ACL reconstruction was much frequently advocated earlier, but now I am of opinion that early ACL reconstruction acts as a brace to the undisplaced MCL tear and we can treat the MCL conservatively. In a high demand patients, probably I will go for both MCL repair and ACL reconstruction in high demand patient. The surgical repair of medial collateral ligament has been demonstrated that the repair of MCL and posteromedial corner injuries are effective and reliable treatment for medial-sided knee injuries, resulting in improved stability and patient-reported functional outcome scores with low rates of secondary failure, published in Journal of Arthroscopy in 2018. Another study which has been published in EFORT that isolated MCL tears, the indication for primary repair is based on resulting quality of the native ligament and the time since injury. The primary repair of the MCL is usually performed and should be performed within acute phase, that is somewhere within 3 weeks after the injury. And do not hesitate to augment the repair for superficial MCL, a surgical technique that can be used when the resulting quality of the native ligaments makes the primary repair impossible or the tissue quality is not that good. And thank you very much. And I will request everyone to please seek your vote for the EC member in forthcoming IAS election. Thank you very much.
Thank you so much, Arun sir. Nice presentation. Again, we will be having so many questions and doubt about repair techniques of MCL. A lot of papers are there which say that repair doesn't work for corner injuries like lateral or medial corner, but we'll discuss about that. Amit sir, I think your talk is much awaited. And Amit sir, you're ready?
Yeah, I'm ready, but
Arun sir, you have to unscreen, unshare your
Yes.
screen. Yes, correct. Amit sir has a lot of presentation, and he has a technique of MCL reconstruction which has been published in Arthroscopy Technique Journal. It's an open access technique. You can go through it, and it's a very good technique, very cost effective, especially in Indian scenario.
can I start,
Yes,
Vinay?
sir. Sure.
Yeah, Unmesh and Arun presented it really nicely. I bring little different flavor. I thought that I'll bring different flavor, but it seems that we all are on the same page and we are doing almost the same thing, right? From Unmesh to Arun. And then I'm going to talk about a little bit of reconstruction. So as both my previous speaker, they say that it has gone long way from the era when we used to say that MCL has to be treated conservatively. And this classification we all heard that type 1 and type 2 can be conserved, but type 3 has to be operated. But there are various other expanding indications. Grade 3 injuries, Steiner's lesion has to be operated, bony avulsion, the avulsion fragment has to be taken into consideration for the treatment. And then MCL incarceration. If MCL is a part of multi-ligament injury, which is around in 80% of the cases, the isolated MCL injury is extremely rare. So in case of multi-ligament injury, I'm little aggressive than other my colleagues to address the type 2 tier of the MCL. We all know that reconstruction gives the best predictive value. There are studies contradicting outcome of early repair. And then there are various methods of reconstruction described in literature. We all are very fond of Laprat's technique, which he described as an anatomic reconstruction, and it has a biomechanical advantages because it has superficial MCL. If you put a stitch, it will make a deep MCL and POL as well. But to my liking, the disadvantage of this technique is 4 tunnels. That means 4 implants. And the cost is very high of these 4 implants. Then there is a chances of tunnel convergence and graft cutout in the tibial side when you fix the superficial MCL is very, very high because the bone out there is very strong and interference fixation is not very always, possible. But the same group, Laprat's group, also published a technique how to avoid convergence. This indicates that they also suffer the problem of the tunnel convergence, when in American people, the femoral condyle is very, very big. Now we talk about what happens, the size of the condyle in the Asian population. These are some of the older studies. This is from 2012, which says that femoral condyle size of the Asian people is smaller. This is similar paper in 2016. But come to the Indian studies. This was the 2021 Indian study by the radiologist. They found that the mean anteroposterior diameter of the femoral condyle is significantly smaller than the European population. This is another paper, again from 2022, a very recent paper, which also says that anteroposterior length of femoral condyle, both in male and female, are significantly smaller than the other study. You can see even the Chinese, Koreans, and the Japanese, our diameter, Asian population, Indian diameter is smaller. So does the Nepali diameter is smaller. And it is significantly smaller than the Caucasians and the Americans. So one size doesn't fit all. In most of my patients, when especially they are female, the femoral condyle is very small, and getting this, the anatomic reconstruction that is described by Laprade is not feasible because of, placement and the convergence of the tunnel. And on top of that, we all know that isolated MCL can be managed conservatively. When it is associated with multi-ligament injury, then there is a chance of having, tunnel coalition, which can damage your primary ligament reconstruction as well. So this is the reason why another paper by George Chahala, who redescribed actually this Kim's technique, in which he harvested the semity, leaving its tibial attachment intact, and rerouted to a epicondyle and to reproduce the POL. So semity was left intact, and this required only 2 tunnels and 2 implants. So it was cost effective. But the problem was with this technique, the failure rate was high because it was not anatomical. If you see the direction of the MCL, it is completely different in Kim's technique and the original superficial MCL. The original superficial MCL is lot posterior in the cortex of the tibia, whereas your semitendinosus semity is lot anterior into the tibia. So it was not able to replicate the true anatomy of the MCL. So this was the technique that we published in 2019. We modified this technique and described this technique into 4 steps. In step 1, we harvested the semity, keeping its tibial attachment intact. In step 2, we gave 2 longitudinal incision into the superficial MCL, which was intact. This can be done in only those cases where the tibial attachment of the superficial MCL was intact. So you give 2 longitudinal incision and weave your semity through this remnant of the semity through the remnant of the superficial MCL, and put some stitch on the superficial MCL so that your semity stays there. Then you take this up and fix into the medial epicondyle, somewhere between the attachment where Laprade described attachment between the attachment of the superficial MCL and the POL. Then you take the limb down and put into the location of the POL. So this creates superficial MCL and POL. Then what I additionally do is I put one more, suture. So this is a cancellous bone. I do not use anchor. Some people use anchor for this. I do not use anchor. I just take a ethibone suture and take a bite into the periosteum in this place, and then suture the same deeper side of the semity graft into the periosteum. So this will act as the deep MCL. So these are some of the example. 34-year-old gentleman, multi-ligament injury. You see that mid-substance MCL tear of this particular patient. Then we decided to reconstruct his ACL. This was clinical examination. So his ACL was also torn, and then MCL, there is a wide opening. You can say that this is grade 2+ opening, but I measured it. It was about 10 centimeter of opening on that side. So I said that in multi-ligament, I'm little aggressive addressing your MCL. So I reconstructed ACL and then reconstructed the MCL with weave technique. And you could see that the joint opening is significantly reduced and it's about 4 millimeter now. This is another case in which there was avulsion from the proximal side. You could see, and this is before the opening. You could see right up to the capsule. There was a capsular tear as well. This was before surgery. On your left side pre-op, and on your right side it's post-op using the same weave technique. This is another third case. You could see that proximal avulsion again. And then on your left side, pre-operative findings, on your right side, post-operatively. Very nicely, the opening closes by itself. This is my final example in which you could see that the patient, after 1 year of surgery, ACL and PCL reconstruction, along with the MCL, and you could see in clinical examination, nowadays, I don't give a long incision. I give 2 incisions, one up and one down, and then railroad the graft as shown earlier. And then you can see that really strong valgus stability. And this is the post-op X-ray of this patient, MRI of this patient after 1 year. You could see that very well placed and healing ACL and PCL graft. And you could see that very nicely healing your MCL graft as well of the CEMIT. There are several, disadvantages as well of this. You need a minimum 20 millimeter of CEMIT length, which is required for reconstruction of both MCL and POL. Sometimes even the CEMIT is very small in female. So in those cases, I have to augment on based upon the size of the graft. Deep MCL is not reconstructed. Only a suture has been applied to reconstruct. Size of the CEMIT is, sometimes difficult. And if you give a smaller incision and do not expose in whole, identification of the exact location of the POL is really difficult. So it requires a little bigger incision than the minimal invasive as described by others. So to conclude my presentation, rather than just thinking that this case is going to go with the conservative management, this case will require a surgery, or this will go for a repair or reconstruction, probably an individualized approach is very, very essential so that you can, comprehensively think about, based upon existing injuries, you can comprehensively think about a treatment plan for that particular patient. It is not only the type classification of the tear, it is the, alignment of the knee, it is the requirement of the patient, it is so many other factors that is very, very essential to understand before taking any decision. My choice, if I get them early, within 3 weeks, preferably within 2 weeks, I repair and I invariably do augmentation irrespective of what is the tissue of quality. Unlike Arun, I augment all the time. If it is delayed, later than 3 weeks, MCL reconstruction is straightforward. I do not look into the tissue quality. I'll just go ahead and do a MCL reconstruction. There are several methods of MCL reconstruction, several techniques described in literature, and the choice has to be made considering many factors. If you are doing a isolated MCL tear that requires surgery, probably I'll do a Laprad's type of anatomic reconstruction. But if it is associated with the multi-ligament where there is a high chance of tunnel coalition on the femoral side, especially in patients who are smaller in size, I'll definitely stay away from anatomic reconstruction of Laprad. Thank you very much. Thank you.
Sir, very comprehensive presentation. Very nice. KD sir, are you there?
Hello.
So Imran has a presentation about MCL injuries. I think Now everybody can just jump in as we want to ask any question. Imran is a small case. We have one case and then we can ask questions. There are questions from YouTube also. So Imran, are you ready with the presentation?
Yes, sir.
So just one case. Again, we will take questions. There are a lot of questions on YouTube as well. Okay, start. Go ahead.
So is my screen visible?
Yes, yes. Go ahead.
Thanks a lot, Arthroscopy Association UP, and especially Ashish Kumar sir and Dr. Vinay Pandey and all the people. And thanks OrthoTV for giving me this opportunity. This is a case of 55-year male who fell from bike and presented to me at 15th day of injury. So this is coronal cut of the MRI. So you can appreciate there is MCL tear, and there was also MPFL injury, and also these are some more cuts, and there was partial ACL tear also. So this was a clinical valgus test in extension. And this was in flexion. So I request esteemed faculty members.
I'm going to ask question. No? You can stop, then we can
how
ask.
to proceed?
Okay, great.
Arun sir, Amit Joshi sir, and Dr. Unmesh, please comment.
There's a question. So Amit sir, you have to unmute yourself. KD sir. Okay. So a lot of time we get these MRI reports of MCL injuries as well as MPFL injuries on MRI scan. Because the insertion of MCL and MPFL are very close to each other on femoral side. So how many times do you take it very seriously that MPFL is also gone along with MCL? Sir, Amish sir, KD sir, Unmesh, Arun sir, what's your take on this? So MRI reporting MCL injuries as well as MPFL tears. How significant do you think it is?
Vinay, most often than not, they are avulsed like a sleeve. They are together. So once you deposit them, the MPFL will fall at its own place. So nothing much of worry about the MPFL as well.
I think I agree. Their attachment site is almost very nearby, but it is not always necessary that they are avulsed. It has to, alarm you that the avulsion is very big from the proximal side. But clinically, it has to be seen. If your patella is easily subluxating or you are able to dislocate your patella, then probably I'll try to address the MPFL as well. If patella is not dislocating, then I'll not do anything to the MPFL. But I'll go with this case. I will repair and augment with the tape.
KD sir, what do you think?
More or less the same, but I think we need to again look case wise, and if there is associated valgus knee, pre-existing history of subluxation. So again, a valgus knee with a MPFL and MCL injury, we need to be more aggressive and look into it. If the alignment is normal and clinically the patella is kind of not too much subluxating, I think a single repair will do the job. Valgus knee.
Unmesh, you will repair and augment also, only repair?
For the MCL?
Yes, femoral side.
Yeah, so the augmentation has always to be there in the backup, definitely. And there is absolutely a good indication of augmenting, which helps in a more aggressive rehab. If we put an internal brace, then the dependency on the external brace goes less. Unless and until the soft tissues are really very good. But since we have already seen the clinical picture, there's a lot of soft tissue contusion and the ligament is not good. An internal brace can really make the surgeon be very confident that he can go with a more aggressive rehab.
So Dr. Unmesh, internal bracing with a fiber tape, or you like to add on with a graft?
Fiber tape. Do a primary repair and a fiber tape internal brace. I probably have a lower threshold because we actually don't know what is happening inside. And we actually don't know what the patient will do. He might remove the brace and start moving around, doing all sort of things which we ask him not to do. So with the internal brace, I think things are more in control.
I
Okay,
think
so you see that there is a tier of superficial MCL also and deep MCL, both on the femoral and tibial side. So what is the technique of the repair in such cases in the mid substance tier?
So mid substance itself is an indication for a fiber tape augmentation. So basically the fiber tape holds on till the primary repair takes care. So you have to repair the deep first. Once the deep is done well, then come to the superficial, cover it up well, use the fiber tape and use the extra limbs of the fiber tape to augment the soft tissue. And then finally the soft tissue sleeve to cover over the fiber tape.
I just wanted to add that for some reason, these MCL injuries, if operated early, are very prone for stiffness. So you need to have an aggressive rehab for these kind of patients. So to have a confidence of giving aggressive rehab after repair, I'm always comfortable augmenting this, So I always augment whenever I do repair because I'm planning for an aggressive rehab.
Arun sir, your presentation had this repair with always tibial side, femoral side, mid substance. It is always fiber tape. So do you ever contemplate doing a biological augmentation in terms of getting CMT and reinforcing your repair with the CMT? Or it is always fiber tape?
No. So if the tissue qualities are okay, for me, this is my algorithm, are okay, not very bad, then I will augment with fiber tape. If the tissue qualities are very bad, repair we could contemplate, then I augment with the autograft. And of late, I'm using Amit Joshi's technique only. It's not like augmenting, it's like totally reconstructing over a repair. What do you say, Dr. Amit? Reconstruction over a repair.
Yeah. You see, what we have to understand that these tapes are not going to replace the tissue. The tissue has to be replaced by the tissue. So if your repair is good with the available good tissue, probably your tape will act as a safety belt for some time till this tissue. If your tissues are not good, just by keeping tapes across the joint, you are not doing justice. For in that case, tissue quality are poor. Probably you do a formal, reconstruction.
Amit Joshi sir, how you will repair this the deep part, the meniscofemoral and meniscotibial part?
You see, if you put your MCL into the place, superficial MCL, the deep MCL usually falls into its place. So what I do usually is I take a bite 1 centimeter below the joint line along the MCL, take a periosteal bite and stitch your superficial MCL into the periosteum of near 1 centimeter below the joint line. So that will take care of your deep MCL.
On the both side, tibia and femoral, both side?
No,
only tibial side.
Okay, Imran, what did you do? Imran?
Yes, sir. So, first of all, I repaired the mid substance tier with the help of ethibond, and then I augmented it with a semi-T graft. I took 2 tunnels in the tibial side and 1 on the femoral side, and fixed on the both sides with the help of RCI screws. And after that, I put staples on the tibial and femoral side. Although not very ideal, as Dr. Amit Joshi sir said that it could be better if it would be in a triangular fashion, and posterior oblique part of this augmentation should have been more posterior. So this was augmentation done.
You take the insertion of semi-T out, so it is like a free graft that you have fixed on the tibial and the femoral side.
Yes, sir. Actually, I didn't have the open stripper at that time. So I took out the complete graft of SEMITI and fixed with the help of RCI screws and staples. So
Why RCI screws have been used?
Sir, so then what should be better then, sir? Arun sir.
Yeah.
This
So why not suture anchor?
Sir, so that the these three tunnels are made and the graft has been put inside the tunnel, RCI screw has been applied. So maybe it
This
will
is there
cause
is
better healing.
subcutaneous side on the anteromedial aspect of the tibia. So these screws, once the edema recedes, they will hurt, and that will also lead to, cortical bone will lead to at times cut through of the graft.
Okay, sir. So according to you, this should be better with the help of suture anchor, sir. Right, sir?
Yeah.
If cost is an issue, to have a multiple suture anchor above and below, probably you can, rather than making these two tunnels into the tibia, you can make a one anterior to posterior tunnel, on the medial side, and pass your graft, so that you have a through the tunnel. I have done in some cases, but this is not ideal. This is for augmentation. This is okay, because your placement on the tibial side is not anatomical. So for augmentation, this is probably okay. This will work. But for a reconstruction, this will not work.
Yes, sir. The purpose was augmentation only. So, sir, Amit Joshi, sir, according to you, in this case also the suture anchors would be better, sir?
Yeah, I think suture anchor is a fantastic stuff here, because medial side of the tibia is very subcutaneous, and then if you see one of the screw, the head is completely out, and this will be palpable in 3 weeks time, and it will be difficult for the patient to tolerate this palpating head of the screw. So anchor is a very good choice in this case, but again, cost effective is the drawback in my practice.
But sir, making a tunnel and putting a graft inside it maybe that will be better healing or uptake of the graft in the tunnel. That will be better. What do you think, sir?
Absolutely agree, but not in the tibia side, because this is a cortical bone, and passing an adequate size screw is not possible. You have to undersize your screw, and the hold will not be that strong. So that is why. And then if you pass a bigger screw, chances of cutout is very, very high. Even with the bias screw, the screw your graft cuts out.
Yeah.
Okay, so Imran, I think little prominence of screw is something which is little uncomfortable. Otherwise, nicely done. So can we take the questions which are there? Thank you so much, Imran.
Thank you, sir.
So quickly we will take the questions. Unmesh.
Yeah.
So in your presentation, you are there, Unmesh?
Yeah.
KD sir, if you want to add something, anytime you can add. So Unmesh, in your presentation, there was no mention of stress X-rays. So for you, MCL in assessment part, you are not very good with, or maybe you're not very fan of getting this, because LAPRAT has a strong recommendation of getting stress X-rays done, because it thinks that's the only way you can have a pre-op and post-op comparison of your results. So do you ever get this stress X-ray?
No, usually the patients who come early, they are in so much of pain that stress X-ray cannot be done unless we give them anesthesia. So that is one part of the problem. And when we are going for these reconstructions, when the patients are colder, definitely it has. This is the most accurate, objective way of comparing both the sides. But again, it is good for chronic cases. So when we are going for reconstruction, they're going for acute repair, then usually they are painful unless you do them under some kind of anesthesia. It is difficult to get an actual picture because the pain will give you false information.
Amit sir, KD sir, Ashish sir, Arun sir, any using this
Under image video.
Yeah, KD sir, go ahead.
Dr. Unmesh, address some vascular injury in the multi-ligament injury.
Teddy sir, we can't hear
Hello.
your voice. Yeah, your voice is breaking, sir. Teddy sir.
Dr. Unmesh,
Yes.
in the examination, this multi-ligament, the vascular injury is percentage of vascular injury in the multi-ligament injury.
केडी बॉस वीडियो बंद कर लो.
Teddy sir, you can switch off your video and then you can ask the question. I think anyway. So we
Sir,
will.
KD sir is asking that what is the percentage of vascular injury in the multi-ligamentous injuries?
Okay, Unmesh, the second question is, Ajay has asked this. So, if I get it correct, then grade 1, grade 2, you are conservative, grade 3, you are operative, correct?
Grade 3 not all. Like if it is grade 3 grade 3 2 or grade 3 3, then we are operative. Grade 3 1 can be kind of borderline.
So this is different between isolated scenario and a multi scenario. It's the same in both the scenarios.
No, it will be different definitely.
Okay, so if you have a scenario where you are in ACL tier and grade 2 MCL tier, so would you like to wait for MCL to heal maybe 2, 3, 4 weeks time, or you will go ahead and fix up in ACL, and then what do you do for MCL? Would you leave MCL if it is a grade 2 MCL?
So now the older teaching was wait, let the MCL heal, now then do an ACL. That was the old teaching. But I think that is not a good idea, because Dr. Arun has already made that point very clear, that if we wait, meanwhile the ACL is not there, the MCL doesn't have an internal support, the healing will be poor. So it is better if the ACL is torn, go in, do an ACL, then on table, check for your MCL. If you're not very confident, you can put a brace, internal brace, and be more aggressive. Do it immediately. If you have got
what's your take?
shades.
Okay, Amit sir, what's your take? So, do you operate grade 3 MCL, or you also treat isolated grade 3 conservatively?
Grade 3 MCL is surgery for me unless someone is, really household kind of person, Otherwise, most of the time, grade 3 injuries are either 3A, 3B, or 3C. Some people now classify. Grade 3 is mostly this is surgical treatment for me, because this is very rare. Very rare you will have a grade 3 injury and all the other structures intact. So it is not only the MCL we are talking about. Look at the posteromedial capsules, and these are also torn. So probably when grade 3, it is your injury is beyond MCL alone, beyond your superficial and deep MCL. It has gone to the POL and it has gone to the capsule also. Probably that has to be, addressed. For grade 3, always surgery.
Ashish sir, you want to add something?
Dr. Unmesh,
Yeah.
नहीं यार बहुत डिस्कशन हो रहा already.
what is the sequence of repair in PCL, ACL, and MCL all ligament injuries?
Okay. So you want to do them in the
Ashish?
same flow? So PCL first.
Yeah.
PCL first, then comes the ACL, finally the MCL.
Okay.
PCL is the mother, the axis. So the PCL has to be done to get the axis right. Then comes in the ACL. Once the cruciates are done, then you can go extra-articular.
Okay. Arun sir?
Yeah.
So you augment all your repairs, or it is any time that you don't augment your repair, you just repair and come out? Is that a possibility, or every repair you always augment with fiber tape or maybe biological graft?
No, of late, I am more inclined towards augmenting it from last 2 years. Before that, if I check the tissue quality is okay, I leave them as such. And that was the time when I was going with the slower kind of rehabilitation. But with more demanding patients, more aggressive rehab, I am happy with putting a fiber tape and doing that, putting a fiber tape and putting those patients in aggressive rehab. Depends on the patient as well, how much the at times there are budget constraints, we cannot put the fiber tape, but if possible, if keep the budget aside, then I am happy to put that internal brace.
Okay. Can I have a question here?
Yeah.
Okay. Now, when we are talking about augmentation, we have the fiber tape as an internal brace and the ligament as a biological augmentation. Now, if you're doing the fiber tape as clearly shown that we want it to be like a seat belt secondary. So we put an artery, we don't want it as tight. So when we're using primary tissue, a semi-T or some other biological tissue, a graft as an augment. So what is the tip from the surgeons that how much tensioning, full tensioning, bit lax? Because if you put the graft a bit lax, I don't think it will work. So what's the take on it?
So the only worry for me, Unmesh, is I use fiber tape for femoral insertion repairs. We have an anchor which is carrying tape in a fiber wire. The only problem is when you are tightening it, we have a tendency to over tighten it because we want to more sure. So these repairs have a strong tendency to become land into stiffness. So MCL repairs are going to get very, very stiff. So you have to be really very aggressive in mobilizing these knees. So for me, a biological graft has some tendency to be like little pliable. But these fiber tapes are very, very hard. So when you're tightening it, initially I used to tighten very, very hard. But now for last few cases, I just put it there and little bit of tightening. Amisha, what do you say?
Absolutely. Your surgical, acumen has to be correct to identify. If you make your tape tight, this will remove stress from your graft. So it does more harm to your graft. So your tape has to be looser than the graft. So your graft has to be adequately tightened, and then your tape has to be like a little loose. And then Arun showed a beautiful technique. If you put I put a thumb forceps which has a different width tapered, and then I put a thumb forceps so that I have a confidence that the tape is little looser than my graft. And then when reconstructing, probably if you are reconstructing both MCL and POL, these has to be tightened in different angles of the knees. It should not be tightened at the same angle. This has to be tightened at different angles.
So the MCL comes at 30 degrees and the POL in extension.
Absolutely.
Amit sir,
okay, and that too in total varus force in the knee joint, and tighten as much as you can as a normal ligament tension you can feel. It's not like lax as you leave your fiber tape. Even if you are augmenting with the tissue, then tighten the tissue as you are doing a reconstruction only, because as Vinay said, that the tissue has some pliability. It will remodel over a period of time according to the need of that particular knee joint.
One more question, staples. How many of you use staples? I am not using staples because they crush the graft. They do not do the tensioning. So a message put very clearly on this platform about the use of staples for the MCLs.
I don't use staples, so that's not my choice.
I had used them earlier and had the same complications as you have described. At times, in the whole graft is cut by the staple sharp points. So, not using off late. Everybody has used them because they are cheap, they are easily available, and they need not to be, make some drill holes. You just tap in and they do the job. But they are at the same time they are very harmful.
What about
removing them? Removing them is again a big headache, big challenge. They come out with a chunk of bone.
Okay, sir, okay, ask. Yeah, Umesh, go ahead.
Sorry. What about the use of spiked washer and screws? Again, that was being used very commonly, but a lot of hardware issues with the spiked washer and screws.
Yes.
So I think that should be put very clearly on this platform.
No, I think with the advent of good anchors and these things, I think those were the times when these anchors were not there, such good anchors. So I have moved towards being anchor friendly and maybe interference screws, anything which goes in the bone, not proud of the bone. So anything which is in the bone is okay. This medial side is very, very not for friendly for any proud devices. So any device which has to be there on the medial side should be buried inside. So that's very important. So anything which gets buried in the bone is fine on the medial side. Amit sir, there's a question for you. So the LAPRA technique has this superficial MCL as a reference, and they take the superficial MCL along the posterior border of MCL, whereas Martin-Lin technique takes it along the anterior border of MCL. So you are taking it on the posterior side of MCL.
Yes.
You are taking the back of the posterior of the MCL and then taking it up.
Yep.
So anytime if you find that your MCL is not so good, so you read out because you are losing the length. So you are going from front to back, is using the length because CMT is far anteriorly inserted. So if you try to bring it back in the case where MCL tibial insertion is not so good, so would you still go ahead and do this posterior border following the posterior border, or you still will follow the Martin-Lin's technique?
No, I do not do Martin-Lin's technique because biomechanically it is inferior. If you read my paper, one of the limitation of this weave technique, if you do not have a MCL to weave, then you cannot weave it. So this technique is not implemented. So in that case, what I do is I put an anchor on the posterior.
Anchor, yeah.
Yes. I put an anchor at the footprint of the deep MCL, which is much posterior than the attachment of your semi-T. Fix my graft first, and then take it up and do the standard weave technique that I have shown. As far as the length is concerned, taking it back and taking up down, length has never been a problem. We have done around 150 MCL reconstruction with this technique, and the length have never been a problem. I'm sure my other able colleague have.
I have read your article. I think one of the flip side of this technique, you have said that the length has to be 20 centimeter. Anyway, so any other thing you should be telling us regarding to be precautious about when using this technique, your technique? Anything that we should be careful about when using technique in your experience, apart from the length of the graft?
I think to any of the techniques, making any of the techniques, identifying true anatomical points is very, very essential. And while doing a POL reconstruction, your semi-membranosus attachment and its direct band where your POL attaches, exposure of this site is very, very essential. And then probably whenever you have an opportunity to expose the medial side of the knee joint, try to identify this place. Otherwise, what happens when your incision is too anterior and you are not able to reach to the posterior part of the knee joint because you have to, it's just about 1.5 centimeter below the joint line and it's way posterior. So if you are not able to reach there, probably your POL location is not anatomic. So superficial MCL, deep MCL anatomy is very, very clear to all of us. But reconstruction of the POL part is very, very critical in the technique, in all of the technique that is described, either say I described or LaPrat's technique. So identification of the tibial attachment of the POL is very, very essential.
So last video that you saw, you have made small windows on the tibial and the femoral side. So now you are routinely making these two windows and doing the surgery, or it's like you open up everything and see and then do it?
No, earlier I used to open up everything, but since I started understanding the anatomy of the POL attachment, I started doing a little smaller incision. These are not small by any means, little smaller. There is a bridge of tissue between the proximal and the distal incision. The tibial incision is large enough to reach to the posterior part and the right up to the joint line. That is the crucial to identify.
I have a question to all the speakers. How often do you use fluoroscopy or C-arm for identification of femoral insertion of the MCL, especially in the cases where you use a small incision?
I do. I use the Schottles point as a reference, and from the Schottles point, then we can identify the.
Because especially in old cases or chronic cases, what is the exact anatomical landmark with a small incision? How do you...
Schottles point has to be identified and used. A dead lateral and draw the Schottles line, and then draw the posterior femoral line and the intersection of the Blumen sides, and then identify the origin of the superficial MCL and the POL.
And what about the other speakers? Do you use fluoroscopy or?
Yes. If we are doing with the smaller incision, then fluoroscopy is mandatory. And whenever you are in confusion, do use a Shyam. There's no harm in it. And in open incision, you can easily palpate the medial epicondyle and recreate your anatomy.
Shwetab, what I do is I start the case. I first locate the adductor tubercle, and from there on, I go to medial epicondyle because there's a relation from adductor tubercle to the medial epicondyle. So if I'm little confused, I'm not getting it because there is edema, maybe fresh case. So if I'm not able to find out my epicondyle with reference to adductor tubercle is very easy to find out. We have a strong tendon there, adductor tendon. You just follow the tendon, you reach the adductor tubercle, and from there you reach the medial epicondyle. If at all there is a problem, I don't find it. It's a very saddle kind of. There's a valley between the adductor tubercle and the medial epicondyle. There's a clear-cut valley from where the MPFL arises. So if I'm not able to find out that because of edema, maybe injury, so soft tissue has swollen up and everything is bulbous, then only I check on Shyam. Otherwise, go to adductor tubercle and from there you try to find out the medial epicondyle. And there's a clear valley, and that again it goes up. That's the point of medial epicondyle. So if I don't find it, then only I go and check in Shyam. Amish sir, what is your take?
No, you see, understanding the medial side open anatomy itself is little difficult. And then understanding now more radiological anatomy creates more complexity to your surgery. And it will kill a lot of time, When you are operating in a multi-ligament setup, when you are doing a lot of surgery, ACL, PCL, MCL, then it will kill a lot of your time. So if you can give a little bigger incision and expose all these anatomical structures that is described by Laprade, probably the Shyam is not required. Why to give a small incision and take a lot of radiation and still not sure that my anatomical position was right or not wrong, as shown by the Shyam? Because it depends upon a lot of things, which angle the Shyam is shooting, in which angle you are putting, and everything. It's very difficult. And then probably I would suggest for the beginner, probably give a little bigger incision so that you can see and then identify the anatomical location and put your tunnel into the correct places.
Amit sir, when these surgeries are not frequent, probably this Laprade medial anatomy chart laminated, pasted over the Shyam TV, some flip-flops type thing are very ready reckoner, which I have done in my OR.
Absolutely. This, if I am in OR, I'll show you one picture that I have kept that picture in my OR. And every time I do my MCL reconstruction, I say I don't do Laprade, I do little different. But this is so important. Their anatomical, pictorial representations are so important that we need to know everything about that.
So one tip for Shwetab is that for only femoral avulsions of MCL, I open a little bit. Rest every MCL you have to open big. So only my indication of giving a very small cut is femoral avulsions. Only femoral avulsion you can go ahead and put an anchor and everything can be done in a small MCL. Otherwise, rest every MCL, TBL, mid substance, reconstruction, everything you have to just open big. Don't shy away. Then you will find it very easy.
I think that your OR team is also important. Probably I always use a Shyam even to check my endo flip and sitting the endo when I'm doing an ACL, PCL. So probably it's a more trauma-oriented team which I have. So the Shyam is always, it just quickly comes in, gets a picture. So it also depends on how comfortable you are. I will not wear a lead apron, obviously, when I'm doing a scopy. So all these things matter. But the important thing is that it has to be done perfectly. Whether it's a large open incision, whatever, the thing has to be perfect.
So there is one last question to Arun sir. Arun sir, the insertion of, as you told, the insertion of MCL on the femoral side is a kind of pointed kind of insertion. But on the tibial side, it's a broad fan-shaped insertion. So your technique, do you apply a technique wherein on the tibial side, is a different method of repair rather than a pointed repair with an anchor? Or it's like a double row kind of repair, which we do in shoulders also. So is it same on tibia and the femoral side, or it's different on the tibial side as on the femoral side?
So to recreate the anatomy, it requires a double row kind of repair on the MCL side, in which there are many papers which have been published in Journal of Arthroscopy showing better results in that MCL, but I have no personal experience of that. I am putting only one double loaded anchor at that.
Yes, sir, what is your take? I personally try to create a broad fan-shaped structure so that it's a broad structure and the broad attachment of the tibial side. So it is always like It's a broad insertion like a double row repair. Amit sir, what do you do for
I-
tibial repairs, not femoral sided repairs or mid substance repairs for that matter?
No, I don't do a double row or anything, because if it is a repair, usually what happens, the periosteum has come up along with it. So if you place that into the play, in its original place, probably the periosteal healing will take place and the broader stump. When it comes to the reconstruction, I absolutely agree. There is everyone is turning towards the anatomic reconstruction. Probably, even if we are putting in anatomical location, probably the broad spectrum of the anatomical footprint on the tibial side is not very well taken care of. But in the repair, I think these are probably a soft tissue and the periosteal avulsion on the distal side, and then only repair of it will take care of it.
And Unmesh, what is the rehab protocol for repairs? You start early or you wait for 3-4 weeks? What do you do? Arun sir and Unmesh, what do you do for repair scenario? Reconstruction, we are very fast in mobilization of the knee and everything. What do you do for the repairs?
So weight bearing is tolerated, toe touch weight bearing. These are for isolated MCL repairs, and toe touch weight bearing and range of motion. If I brace them, usually I brace them now more often. After a week, I start them on range of motion mobilization and aiming up to 90 degrees of flexion in about 3 weeks. And then full weight bearing after 3 weeks.
Unmesh, what do you do? Okay. Yeah,
So once the pain goes down, that's usually 24 hours. On bed heel slides can be started. Again, it's all augmented. The augmentation has to be there so that we can aggressively rehab. So internally braced, internally augmented. On bed knee bending from day 1, 24 hours once the pain goes down. Toe touch weight bearing 3 to 4 weeks. 4 weeks is usually with an external brace and with an augment inside. And a target of 90 degrees of movement around 4 weeks. Quads, statics, isometrics, VMOs. That's yeah.
Neeraj, you are there, Neeraj? Neeraj?
Yeah, I'm here.
So, Neeraj, what is your take on repairs? So, how do you repair and how fast you mobilize your repairs?
Actually, whenever I'm repairing only the mid substance tier. So I repair with a ethibond and I always put a internal brace. But still I wait for at least 2 to 3 weeks, let the wound heal because we have given a large incision. So I always wait for 2 to 3 weeks, then I start heel slides. I never start on day 1. And in 2 to 3 weeks, I am seeing the stiffness is there, but not that much. It usually comes within 2 months, you can get the full range of motion. So I go a little slow. Even despite internal brace, I go a little slow.
Shweta, what do you do? So you don't repair femoral sided and tibial sided injuries, only mid substance you repair.
Femoral side is little aggressive. Repair means I'm telling the ligament, the mid substance when we repair. For these femoral side injuries, kind of avulsion injuries. So we are fixing it. So that I'm little aggressive. Because in the mid substance, I have seen the capsule and everything is torn. And tissue quality is not very good when there is a mid substance here. So there I go a little slow. But for femoral avulsions, I'm aggressive because that is kind of avulsion. So I put a Schuster anchor over there. So I'm a little aggressive in femoral, but still I always wait for the wound healing to happen. Then I start mobilization of MCLs. And for tibial side, Steiner's lesion kind of things, I'm again slow. I go at least 3 weeks of immobilization for Steiner's lesion and other tibial avulsions. For femoral, I'm a little faster because the healing is pretty good in femoral sides.
Shweta, your take? Shweta, what do you do? Unmute yourself. Unmute.
Hello.
I'm also a little slower on the rehab because similar to Neeraj, I found that within 2 months, usually the range comes. So for the first 15 days, I'll rather mobilize only up to 30 degrees, focus more on patella gliding and quadriceps static, and start with heel slides. And eventually at the end of 2 months, usually the full range is there. So I'm a little slow, especially in the repair scenario.
Okay, so one last question in the chat box. Patient with 1 month-old injury, neglected partial tear or MCL. Why the patient walks with a flexion deformity? No associated injuries. Amit sir, what is your take? So patient is MCL, partial tear, and 1 month old, walking with a flex kind of knee. So what's your take? Why this is so? This is a Dr. Mozimbul Siddiqui has asked this question.
There could be various options, but with partial tear, grade 2 tear of MCL having a flexion deficit is just simply the patient was not adequately rehabilitated earlier. That is the only answer I can give to you. If other structures are intact, if there is no, associated bucket handle which has locked it, or even, ACL tear which has cycloped, which has caused the extension. Only reason is because of the pain, the, knee has a attitude to go into the flexion. And if you keep your knee flexion for about 12 days, 2 weeks, then your posterior hamstring goes, tight, and then getting extension is very difficult.
So I think we had very good session about MCL injuries, assessment and repairs and reconstructions. Anybody has any question we can ask, otherwise we close the session. Okay, so I should thank OrthoTV for their contribution towards providing us the platform. They've always been very nice. It was a very short notice program that we organized, and they were very generous to be providing their platform. Ashish sir, are you there? Ashish sir, Dr. Ashish? I think sir is not there. So we can close now. Thank you so much for participating, and it was a wonderful session. Thank you, Amit sir. Your presentation is always worth listening to. Always something to learn out of the presentations. Unmesh always as elegant in his presentation as always. And Arun sir, all your experience was there in your presentation. Thank you so much. Thank you very much. Thank you everyone.
Thank you so much
Good
for the
night.
option.
Take care.
Thank you, Dr. Vinay, for your kind words.
Bye-bye.
Thank you, everybody.
Thank you. Good night.
Thank you. See you soon all in Nepal. Thank you very much.
Sure, sir.
Bye-bye.